If you can't hear me and you can't see my screen, I can say so in the chat and we'll hopefully get that fixed. So good afternoon, everyone. My name is Nicholas Webb, and I'm glad to be here today, although I'm very sorry that I'm not going to get the opportunity to introduce myself to you in person like I had hoped to do. I'm a longtime member of what is now LAMPHHS, but this would have been the first annual conference that I had attended in person, so I'm sorry to miss it. I can fool myself by thinking that most of the time we're working with the history of medicine. Right now we're living through the history of medicine. So for those of you who haven't met, I'm the archivist and digital preservation librarian at New York Medical College, located in Westchester County, about 45 minutes north of New York City. I joined New York Medical College at around this time last year, but before that I had been working for about a decade as the digital archivist in the LAMPHHS archives of the Icahn School of Medicine at Mount Sinai. And if I were giving this talk in person, this is where I would stop and wave to Barbara Niss, who I'm sure most of you know, and give her credit for being my professional mentor in the world of healthcare archives. My talk today is going to be something of an exploratory talk on the subject of digital archives in healthcare settings. I'm really interested in connecting with other people at other institutions doing this kind of work and getting feedback about it and hopefully starting an ongoing conversation about it. As I said a moment ago, at Mount Sinai, my job title was digital archivist, and that was my primary focus in terms of what I did day to day. Although I also spent a fair amount of time working with traditional paper archives, which is what has inspired me to make healthcare my professional focus. Today I'm a lone ranger at an institution with a long and fascinating 160-year history, and I'm the first full-time permanent professional archivist on staff in that 160-year history. So that means that I wear a lot of hats, and I've been working my way through the backlog of physical material here, including a basement room full of uncatalogued rare books in various stages of deterioration. I've had a lot of time to think long-term about what I want my long-term plans for digital archives to be at New York Medical College, and I'm interested in opening up a broader conversation with my colleagues in LAMPHHS about what our various institutions are doing and what our best practices ought to be. Sometimes I'm interested in doing a more formal quantitative survey to get a sense of the state of the field. So as I go, I'm going to be asking some questions that I will hope will inspire you to reflect a bit on how your institution is doing digital archives and how your particular circumstances affect that. The title of my talk today is Collecting and Sharing Digital Collections, Institutional and Professional Contexts as Archivists. In terms of our institutional contexts, health sciences archivists, librarians, and museum professionals often occupy an unusual position. As curators of medicine's past, we're concerned with historical records, historical topics, and historical context, which makes us similar in many ways to our colleagues who work in cultural heritage institutions or in special collections divisions devoted to the humanities and social sciences. Organizationally, however, we're often based out of medical school libraries, so most of our coworkers are medical librarians, and where the immediate organizational focus is on providing access to up-to-date resources, in particular these days to electronic serials. And this means that we often find ourselves acting as advocates for history, fast-paced environment where the typical library patron isn't the latest research findings. Looking forward to hearing some of you speak later today on what you're doing to engage students and community members in the history of medicine. But in terms of digital archives, one immediate implication for our work is that we may not have access to the same understanding of what we do that might be present in a more traditional cultural heritage environment. In the context of a university special collections department, where the collection of historical materials for use by scholars is a significant part of the broader institutional mandate, it's generally understood at this point that collecting digital archives is something that institutions should be doing, even if in many places the realities of budgets and of technological complexity have made that difficult. For starting from scratch in a medical library, we may have to make the case for digital archives being a function at all, and then advocate for the unique resources we need. My own thoughts on this subject have been shaped by my experiences at the Icahn School, which is the top US News ranked medical school not to be a part of a larger university system. Because we were not affiliated with a larger university, there were no opportunities to use systems existing elsewhere in the university library to manage our medical school and historic hospital content. And so we ended up building an archival repository from scratch. I'm curious to know what the experiences of my LAMPHHS colleagues in larger institutions are. Do you have access, for example, to a university-wide preservation repository? Equally important, do you have the ear and the time and the ear of university-wide IT staff in implementing digital archives projects? Or do you find yourself in an organizational silo separating the School of Medicine from the broader university library? There are additional institutional contexts which add complexity to the project of collecting the history of the health sciences in the digital era. While there are certain types of long-term institutional content, such as newsletters and annual reports, which have survived the transition from paper to PDF relatively intact, the nature of the healthcare enterprise in the 21st century means that an increasing amount of primary sources are created in complex digital formats. We're all familiar with the rise of electronic patient records, and I think it's probably for the best that we are not expected epic managers on top of all our other job duties. But when we're talking about documenting the broad-scale research and teaching and clinical care activities at our institutions, as opposed to the care of individual patients, we do have to think about how far our responsibilities stretch. And this leads to tricky questions about our own professional identity. How, as archivists whose mandates include digital records of long-term value, we relate to other digital information sources on our campuses. At Mount Sinai, one of my major projects, and sometimes major headaches, was managing the integration of our archival repository with the content management system used for the day-to-day management of clinical policies. These are undeniably important records, documenting important aspects of hospital practice, and frequently consulted in their expired versions by our risk management department. But keeping our archival collection in sync with this separate, extremely complex data source turned out to be a time-consuming project that stretched me to the limits of my own IT skills. The situation becomes particularly complex when it comes to documenting the work of our researchers. Days in which we could take custody of somebody's lab notebooks on the date of their retirement are no longer with us. So if our institution has a repository for faculty research output, or a repository for research data management, is the archivist a stakeholder in this project? And if our institution doesn't have these things, should we be pushing to create them? At Mount Sinai, our archival repository was originally scoped to be an institutional repository for the broader community, as well as an archival preservation repository. But that use case was never implemented due to the lack of faculty buy-in. At the New York Medical College Library, we have an active scholarly communications department and an institutional repository for preprints and publications, which we share with the rest of the Touro College and university system. But I'm still working out how I, as the archivist, relate to this distinct institutional function. And so I ask once again, out of my own curiosity, what my colleagues in other institutions are doing. What types of repositories does your institution maintain? Do you have colleagues in your library focused on data management or on research output? The question of what types of digital materials qualify as digital archives is not limited to the health sciences. Several years ago, Karen Raddick published a fascinating article on the subject of ambiguity in the digital archivists, based on a close reading of several task force reports and a content analysis of job listings. We looked into the question of what exactly a digital archivist is. Is a digital archivist someone who works with born digital archival records? Or is it someone who is responsible for the digitization of analog materials and the management of their digital surrogates? What she found, and what I suspect is the case for many of us, is that the answer is both. That was certainly my experience at Mount Sinai, and to the extent that I've begun a digital program here, it's my experience at New York Medical College as well. In terms of our physical holdings, which for most of us extend at least to the 19th century, if not much further back, our professional values as the curators of these materials really mandate that we create digital surrogates. In an online era, scanning our collections and making them available on the web is important both to promote and publicize the existence of our archives and to carry out our mission of making our collections accessible to researchers, including the wide audience of patrons who want to engage with our holdings but don't have the resources to visit us physically. The scanning of physical analog content is of course also a major preservation task, both for print, particularly 19th century print on acidic paper, and for audiovisual materials in deteriorating physical formats. But as professionals whose mandate also includes documenting current activities in our areas of expertise, we know that in the digital era, the majority of primary sources documenting modern medicine and health sciences are born digital. If we're lucky, these arrive at our archives in formats which are easy to manage, such as well-formed PDF files whose visual layouts mimic a physical print document, or in photograph collections which are already well organized with accurate metadata. But, as I'm sure many of us know, born digital records, just like physical records, typically do not arrive at our archives neatly organized. I graduated with my MLS in 2008, and I've been working in the field since then as a digital archivist. One of the most exciting developments in the field in the past decade is the rise of an increasingly robust and sophisticated suite of software tools for the management of complex and disorderly bodies of born digital records. Open source Archivematica and the proprietary Preservica are two of the big names in this field. But implementing complex software tools will be a major commitment of time, of expertise, and of course of budgets. And I think all of us often find ourselves working in environments where these resources are scarce. So like the clinicians whose activities we document, we as archivists have to engage in triage. If you followed what we've been doing at Mount Sinai over the past 10 years, you might have heard about our ongoing experiences with DSpace, which was the software platform that we chose to build our archival repository on. DSpace is a widely used open source product for digital repositories, which was originally developed at MIT for the management of faculty publications. In the course of our experiences using it for a digital archive, we found that we were pushing it to the limits of what it was capable of. The title of my talk began as Collecting and Sharing Digital Collections, and one realization that I came to over the course of my work with DSpace, that these are really two separate functions. The platform which works best for managing and preserving digital content may not be the best platform for making that content accessible to the web with current standards, particularly when issues of information security for sensitive materials become involved. And for us in healthcare, of course, this is an especially pressing issue. So again, I'm curious to hear from you as my colleagues how you've navigated these issues. Has your institution focused on digitization for the web? Does recent Born Digital material issued by your institution become part of a publicly accessible web archive managed by the archives department? Or do you manage these items separately from scanned historic material? Do you use separate tools for preservation and access? Are you using preservation tools at all? I know from my own experience that starting and maintaining a digital archives project can feel extremely intimidating. I'm interested in connecting on these topics with my colleagues here in LAMPHS and in sharing our experiences as I work out how to start a digital archives program at my institution as an already overstretched lone ranger. But I think we have reason for optimism. The other exciting development in digital archives over the past decade, which very much did not exist when I was a newly minted MLS, I see my warning, so I'm moving a little fast here, is the increasing recognition of the fact that most of us do not work in environments where we have unlimited access to resources. Typically, we do not have dedicated staffs of web developers and systems administrators on hand. There's an increasing recognition in digital archives that the perfect is the enemy of the good, and an increasing emphasis on smaller, simpler tools with fewer points of failure. If you're just getting started tackling these issues at your institution, one theoretical insight which digital archives professionals have really started to emphasize is that the activity of digital preservation is not something done by computers, where you can implement a one-size-fits-all software product and forget about it. Something done by people committed to the care of a particular collection, particular collections, in particular institutional circumstances. Us, as curators of the health sciences heritage, we're committed to preserving the history of medicine for the benefit of future scholars and researchers. I believe that we can find ways to meet this challenge in the context of our own unique professional settings. So thank you. I hope you enjoyed the talk, and please reach out if you're interested in discussing some of these issues. And I hope to meet most of you in person, possibly next year in Madison.
Great, thank you, Nick. Next up, we have a lightning talk from Robin Naughton from the New York Academy of Medicine and Melissa Graff from the Medical Historical Library at Yale. The title is Reach Out and Rethink, User Feedback and the Medical Heritage Library.
All right, thank you, Megan. Robin is putting the presentation up, I believe. Or maybe not. We can do it my way. Oh, there we go. Okay. Okay, thank you everybody for joining us for this lightning talk. Again, I'm Melissa Graff. I'm at Yale, the Cushing Medical Library. I'm also president of the Medical Heritage Library, and Robin Naughton will be joining me for this presentation, and we'll be doing the lion's share of it. Go ahead, Robin. You can see the title of our presentation, Reach Out and Rethink, User Feedback and the Medical Heritage Library. Robin, go ahead and turn the page. Yeah. For those of you who are not aware of us, the Medical Heritage Library is an online consortium of a number of medical institutions with history of health science collections. And over the past 10 years, we have been digitizing thousands and thousands of items. You'll see we have over 300,000 items, 4 million images in Flickr, as well as multiple views and downloads. You're welcome to visit us on any of our sites, and we also have a website, medicalheritage.org. Go ahead, Robin. The reason we're providing this talk is because we wanted to describe some of our efforts to better understand our users. So in 2018, we instituted our own fellowship program, and under the fellowship program, we brought in Emma Brennan-Wydra, who conducted a usability and outreach study for the Medical Heritage Library. And the study was invaluable because it helped us to identify multiple areas that we really needed greater engagement. And you can see some of them described on the slide here. One area that our 2019 fellow pursued was creating online shelves or curated areas on different themes. So if you go to the Medical Heritage Library, you'll see shelves related to vaccination and to disability. A fellow that we're hoping to hire this year will be working on developing a virtual conference and helping to leverage and expand our social media presence. But for this presentation, what we're going to do is focus specifically on our website, www.medicalheritagelibrary.org. And in this, Brennan-Wydra wrote in the report, it is not clear what you're supposed to do when you arrive at the Medical Heritage Library WordPress homepage. And so we made it clear. Go ahead, Robin.
Hi, everyone. I will start talking about this from here. So the website, as you can see on the left, was the old version of the website. And one of the things the research showed is that it was a little static. You didn't quite know what to do. And a lot of the new information that's been constantly populated, particularly the blog information, wasn't clearly visible on the homepage. So one of the things we did to really try to shift the site is to redesign it in such a way that it brings a lot of the information forward and really makes use of the space. So the website on the left, one of the big things we did is shifted from a static site into a more dynamic site. And what I mean by that is that at the top level, you can see that we changed it into more of a slider. So on the website of itself, you can see different images appear in this slider. And the images that we created for this is really a compilation of what's in the Medical Heritage Library. And these are all images from the library and from the collections that appear there. And the next thing we did was really think about how do we bring the blog forward, so that way when new information is posted on a regular basis, and we're constantly updating the blog, we want to be able to see that information quickly. So if someone comes to the site, in the first impression, they can see exactly what's happening, what's been happening, and what's new in the blog, what's being talked about, and what's important. So the dynamic nature of that is that each time a post goes up, it's available here. It can be a featured item. It can have a gallery. We can do many things with the available items there. And the next piece of information that we really looked at is to really streamline the navigational structure and the organization of the content. So it has fewer top level tags, categories, but it's more informative and helps people to really navigate through. We really also try to pull the search forward a bit and created a search page so that they can search dynamically through the site and see all of these things. So one of the things that I do want to do a little bit of is just to talk to a little bit about some of the additional changes that we made. One of the additional changes that we made, we also wanted to create a space for the primary sets. And in creating a space for the primary sets, we were able to highlight the work of our fellow Kelly as she created the vaccinations and so forth. Another thing that we did do so in creating this space, this is my space, those are primary sets. So in creating this space, the primary resource sets, our information can be easily added here as the fellows do their work and generate this content, which is really a big part of what we're trying to do in the next phase of the project. In addition, one of the things we also wanted to do in terms of the content was really shift it from static into more dynamic again. And this is particularly in terms of some of our list of information. So the State Medical Journals project, we really went through and created an amazing resource that's available. And on the website, we developed a long list of those so users can easily get to the state journals and particular journals that are part of that state journals. And in the redesign, what we did is we generated and created a table. So it's more dynamic and you can search easily to find information and you can really get a sense of what is available. And it's a quick way for you to get any kind of information that you need from the site. So I'll show you that a little bit. So for example, so this is our state medical journals page. And on this page, as you scroll down, you can see that our journals by state, you can now sort by state. You can sort by title if you're looking for a specific title. You can also sort by date if you're looking for something at a specific date and time. In addition, you can do a search for a particular journal and it will start to bring that up for you. So a lot of the work that we try to do with this site is really make it easy for users to get to the information that they want and the information that they need. One last piece of information in terms of our search, we created a top level tag that says search your collections. And when you do, you get directly to our available search options and you can search the collection as you see fit. And this is a way for you to get to the full text search tool, as well as understand how the Internet Archive search also works with this.
So Robin, I think we're done.
I think we are. And
right.
So that brings us to the last slide before the thank you. And this is the Flickr slide. And this is here so you know that we have pulled over 4 million images out of the Medical Heritage Library collection, and you can access those images on Flickr. And you know, you can do a search and you can search for images. You can even search by color if you so desire, if you're looking for something very specific. And it's an amazing resource to find images for anything that you're working on. Thank you.
Thank you.
Sounds great, thank you. Our last presentation is from Gabrielle Barr from Northwestern University called Going All Out to Get People into History.
Gabrielle, you may be muted still.
Okay. Okay. Good afternoon, and thank you for attending my presentation, Getting People into History Means Going Out of the Box, that discusses the outreach conducted to promote the 12th General Hospital Collection as a second-year National Library of Medicine Fellow at Northwestern's Galter Health Sciences Library and Learning Center. During World War II, Northwestern University physicians and dentists, Chicago area nurses, and enlisted men from all over the country treated their ill and injured comrades in Algeria and Italy as the 12th General Hospital Unit. As part of my fellowship, I processed the collection of James A. Connor and Michael L. Mason, who served in the unit, producing the finding aid, uploading images and documents into Galter's digital repository, Digital Hub, and creating an interactive digital exhibit. To draw attention to these resources and cultivate an interest in the collection, the director of the library, Christy Holmes, requested embarking on some sort of outreach initiative in May of 2019. It was the job of those in the Special Collections Working Group, as well as Karen Gutzman, who is my fellowship preceptor, and Mary Ann Zeminski, who has substantial design experience, to decide how we wanted to highlight the exhibit. The scale of our publicity efforts evolved from being a simple presentation to library staff to a multi-dimensional lunchtime speaker event to launch the exhibit. We put forth an ambitious schedule that was amended according to our allotted time schedule, staffing capability, and funds. Early in the process, I put forth recommendations for potential speakers, as well as assembled a budget. Dr. Sanders Marble, who is a senior historian for the United States Army Medical Department, agreed to speak about surgery during World War II. To begin reaching out to potential attendees, I collated a list of individuals, veterans associations, academic departments, and cultural institutions. I created model emails specific to particular groups, as well as a corresponding guide for how to communicate with these entities. But ultimately, the team used one email template that could be altered accordingly. The link to the Eventbrite page to RSVP was incorporated into the email, and phone calls were made to those who did not have email or social media accounts. The team also performed genealogical research to notify any living veterans and their families about the event, using sites such as Ancestry, Find a Grave, and whitepages.com, as well as newspaper databases and Northwestern publications. Conducting genealogical research was a very interesting but time-consuming endeavor. We got through about 300 names. We were not able to locate any living member of the unit, but we were able to track down some of their descendants. The medical school's Office of Alumni Affairs suggested composing handwritten notes as a way of connecting to an older population, which prompted the creation of this invitation suite designed by our team and printed with Vistaprint. The invitation contained information about the event in the collection, and we mailed nearly 200 personal letters to family members that included as many specifics about their loved one's tour of duty as we knew. To expedite getting a response for logistical purposes and forming a relationship with these honored guests, I followed up with phone calls. Because many of the children of the veterans could not attend in person on such short notice, the team decided to set up remote streaming. Our team employed a variety of virtual platforms to draw attention to the event, from social media to the digital signage on the monitors at Galter Library. Other Northwestern departments and some of the veterans associations contributed to spreading the word. We also posted flyers around the library and emailed them to some of the groups to share with their members physically and electronically. Finally, we collaborated with Northwestern Feinberg School of Medicine's Office of Communication to garner outside publicity. A promotion for the event was aired on WBEZ NPR the morning of the event, and then a write-up was posted on the website a few days later. It was also covered by the Chicago Tribune. Because Galter Library was undergoing renovations, we could not install a physical exhibit. Inspired by the traveling exhibits of the National Library of Medicine, we designed our own banner display to be shown at the event that could be brought out for other occasions like Veterans Day and Memorial Day. Corinne generated the panels in PowerPoint using the text and images I had written and selected, and then Mary Ann and Karen converted them into PDFs and transferred them over to Vistaprint. This experience taught us the importance of establishing the color scheme and design elements early in the process, getting a better sense of word count before jumping into creation, and leaving enough time for revision given the number of details. During the course of the project, we had the opportunity to meet the great-nephew of Katherine Baltz, who acted as the unit's chief nurse, and he allowed us to show parts of a 2005 interview she did with the Army Nursing Corps. I selected 4 clips, and Karen, using Adobe Premiere Pro, edited and combined these segments into a presentation. We also added closed captions to be 508 compliant. Another component of the event was a tribute video set to the World War II Army song, Over Hill, Over Dale, that we believed would instill the audience with the spirit we wanted the ceremony to have, while also providing something aesthetically pleasing to those who arrived early. Around 20 family members of the 12th General Hospital Unit attended, traveling from all over the United States, from Colorado to Illinois to Boston. It was really incredible. Not wanting to put anyone on the spot or emphasize a particular type of experience over another, we had each person during the event stand and briefly discuss who they were attending for. This was by far the most heartfelt and memorable aspect of the entire program. The families reminiscing were very knowledgeable about their relatives' role in the war, and the audience really enjoyed hearing their stories. The team debated how to incorporate living veterans into the schedule. We ultimately chose to applaud those who are currently serving or have served, mention some of the hardships veterans today face in the director's closing remarks, and list some Chicago associations that aid veterans on the back of the program. Lastly, we partnered with Susan Saharsky, who is the archivist at Northwestern University Memorial Medical Archives, in showcasing the papers and memorabilia physically in the library. And we also had a large monitor in the corner for guests to explore the digital exhibit. There were countless other aspects of planning the event, but one of the best actions the team took was recruiting our library colleagues to assist that day, carrying out tasks like directing guests, distributing programs, and setting up and breaking down the room. Between 150 and 160 individuals physically attended the event, with more than 10 people watching remotely. We received positive reviews at the time of the event and in the weeks following. Of course, there were mishaps, ranging from issues with remote access due to having to change our room at the last moment to underwhelming participation in the tours. Nevertheless, there is no question that the event and the initiatives we carried out to market it raised awareness about the 12th General Hospital Collection and the fact that the library, which houses other historical materials, tells the story not only of Northwestern, but also Chicago, which is why it was so nice to have a broader community present. In the immediate aftermath of the event, the library received a few in-person and remote reference requests about the collection, primarily from relatives, but also from those who had read the Chicago Tribune article and wanted to see the banners. There presently are no concrete metrics for how many individuals outside of the library have looked at the digital exhibit, finding aid, or content on Digital Hub. The banner display, which served as a model for subsequent exhibit about women in Northwestern Medical School, has been featured at the First Division Museum at Contiguity Park and may in the future travel to other locations in the Chicago area. We have also highlighted the collection in our efforts to champion it at conferences like the Chicago Area Medical Archivist meeting last fall. By engaging in this project, we learned several lessons that will guide us in future special collection ventures. Among the most important include ensuring that the event remains focused on a central theme, dialing back on some proposed ideas and prioritizing amongst the ones selected, the value of debriefing about experiences and hard numerical figures as evidenced by the graph about how we utilized our budget to make more informed decisions, and finally, how essential it is to assemble a team with assorted talents and capabilities, especially when operating with a limited budget. And I would like to acknowledge those on my team and others at Galter who contributed to making this event a success.
Wow.
Great, thank you. I guess we'll move on to Q&A.
We've stunned everybody with the presentations. I know, it's all good. There is something in the chat from Dawn Lucas. Gabrielle, how long did it take you to plan everything?
We had from about mid-May to August 14th to plan this event.
Gabrielle, is it possible to tell us what your budget was? This doesn't look cheap.
Our budget came because I was a fellow. My preceptor also received money from ORISE as part of the fellowship, and so they get about $5,000, and she had used some of it, and so we had about a little over $4,000 to spend on this event. For most of our activities, the university, library, Galter obviously paid the staff to work on some of these projects that were outside their normal job scope, and to do other little things like printing the programs and things like that came from the library, but the others came from a budget around $4,200.
Thank you, Gabriel.
There's other questions I see. One is to myself and Robin. How many users did you test for the usability study, and who did you test? Our fellow used several methods. She was doing a kind of a larger scan of the users of the Medical Heritage Library website. And so she looked at metrics. She also did some focus groups and had interviews one-on-one with people just to see how they were using the site. I don't know if there were more specific things that she did, although there's certainly opportunity to do more. Robin, do you have anything else on that one?
No, I don't have too much more to add. I think she definitely did interviews, which I think were valuable. She did the metrics on the site to kind of understand what we were doing, and not only on the website, but overall like social media and so forth. And I think the information she got, there was a survey. So some data came out of the survey, some data came out of interviews, and I think that really informed the final report that she provided.
Mm-hmm. I see Phoebe has asked for Gabrielle, has the World War II event resulted in new collections for the archives?
I am not certain. It was a fellowship, and so I left. My position was only until September. There were some talks that some of the family members were interested in donating their materials. I'm not sure. Katie, who's present right now, maybe can speak more to that, but I don't think anyone has donated at this time yet.
This is Katie. We haven't gotten any donations, but it would be, you know, great to follow up with family since Gabrielle started that, you know, with reaching out to everyone.
And then Gabrielle, another question for you is from Shannon Odell. Did you know about this project before you began your fellowship?
I did not know a lot about the project before I began my fellowship. When I came to visit, Katie had talked a little bit about the 12th General Hospital collection and that I would be processing it. A lot of the details, and definitely not this event, were really in order at that time.
Okay. All right, I'm looking, did I miss any questions? Any other questions for Nicholas, myself, Robin, or Gabrielle?
I actually have a question for the Medical Heritage Library, which, do you have any plans in the future to explore the possibility of building tools that would let users curate their own selection of content? Because I know, when I'm doing research in the Medical Heritage Library, it's such an amazing resource of stuff, but sometimes surfacing stuff just through the Internet Archive interface can be difficult. So I'm curious if there's any plans to do stuff around that.
That is a wonderful question, and actually something we're very actively engaged in right now. You know, we have so much material, it is hard sometimes to surface the kinds of things you might be looking for. You know, we've prepared an advanced search internally, but it's kind of seeing its age right now, so we're having some issues with it. So what we're hoping to do is we're working on developing a grant and to help us move forward on advancing our interface in a way that it's not there yet. So stay tuned. But yeah, we're definitely thinking of ways for people to have greater access.
Great.
All right. I don't see any other questions. Last call for everybody. All right, then feel free to email any of us presenters if you have any other questions, and I will turn it back over to Rachel or Megan.
To Meredith. You're going
Meredith.
to meet all of the program committee members over today and tomorrow. So thank you.
Hello, everyone. Can you hear me okay?
Yes.
Hi. Okay, great. Hi, my name is Meredith Gozo. I unfortunately haven't met anyone yet because this is my very first conference, but I'm so pleased to do this virtually, and I'm very pleased to be presenting our next group of speakers. So this session is Access and Outreach Part 1. We have 3 different talks that are happening over a 1-hour session. So if you can reserve your questions for the end, that would be great. And for those of you who are speaking, if you'll just let me know, I will plan to hold up a 1-minute sign, but if you prefer that I kind of interject at that warning period, I can just kind of jump in really quickly and let you know that you just have a moment to wrap up. Okay, so our first speakers are Lucy Waldrop and Rebecca Williams. Lucy is the Assistant Director and Technical Services Head at Duke University Medical Center Archives. And Rebecca Williams is the Archives Librarian for Research, Outreach, and Education at Duke University Medical Center Archives. So I will turn it over to you.
Hi, this is Lucy Waldrop and Rebecca Williams from the Duke University Medical Center Archives. Today we're going to present on Doctors, Covered Entities, and HIPAA, or How We Learn to Stop Worrying and Love the PHI. This is Lucy and I work in technical services. Rebecca is the reference archivist. To researchers, the words restricted and unrestricted are two of the most important words in a finding aid, as it can be the difference between having access to the materials they want and not having access to those materials. It is the job of an archivist to weigh the risks of making personal information or confidential institutional records accessible in their process collections. The most common options for dealing with this type of content are redacting the sensitive information in the document, restricting the entire document, or not accepting documents that contain sensitive or confidential information. Historically, archival repositories carried out these actions to maintain good donor relations and because it is the ethical thing to do. In a legal sense, this all changed for medical archives with the 1996 enactment of the Health Insurance Portability and Accountability Act, or HIPAA. These changes came incrementally from the time the Act was passed in 1996 to when compliance of this rule was required by individuals, organizations, and agencies that met the definition of covered entity by April of 2003. Covered entities include healthcare providers, health plans, and healthcare clearinghouses. As part of the Duke University Health System, the Duke University Medical Center Archives is a covered entity. What does this mean? It means that personal health information, or PHI, such as names, dates of birth, medical records, diagnoses, images of patients, social security numbers, and other personally identifiable information cannot be made public without violating the law. This does not mean that archives that are covered entities cannot collect these types of records. But it does mean that archives that are covered entities need to be aware of the PHI in their collections because there are very real legal ramifications for allowing access outside the proper channels. It wasn't until the HIPAA Omnibus Rule of 2013 that covered entities could legally provide access to these records without going through the rigorous IRB process. The Omnibus Rule makes records with PHI available 50 years after the patient's death. This means that archives that are covered entities must know the death date for each individual for which it holds that PHI in order to make that content available. This can become very time-consuming, which is why if the death date is not easily accessible to the archivist, archival materials containing PHI often remain restricted.
Hi, so this is Rebecca speaking now, and I'm going to talk about two different legacy collections in our archives that contain PHI and provide a brief overview of how they're accessed and the types of projects that utilize them. So the first collection is the Department of Obstetrics and Gynecology records, and one series in this department collection contains delivery and procedure logs. So in this series, there are 43 logbooks, which are pictured here on the shelves, and they're dated from 1930 to 1965. And they're exactly what their name suggests, books that log procedures done by OB-GYN physicians, so mainly deliveries. And the first case is fairly standard or traditionally used case, one which I'm sure many people here have experience or familiarity with. So we were contacted by an experienced faculty researcher at another North Carolina university who was researching motherhood, fertility, and the language around these topics. And because of their research, they were very familiar with the IRB process and willing to go through it again. So we worked together with Duke IRB and their home institution's IRB in order to get their research approved. And just the key takeaway is that it's never too early to develop a relationship with your IRB. Particularly for us, we're under the School of Medicine, and so people don't always know what to do with us in the bureaucratic line. And so often there's a lot of emails and bouncing around to multiple contacts because they're not quite sure what to do with historical research rather than clinical research. And so also when working with researchers outside your institution, they typically need a sponsor with their IRB. So it's just always great to make those relationships now, if possible. And the second case is with a year-long special interdisciplinary undergraduate research project. Kind of a mouthful, but as part of this research project, there were groups of undergraduate students who had 1 semester to start and complete their research. And so given this short timeline, we were concerned about having them go through the IRB process because we couldn't guarantee whether or not they would receive approval in time. So, but that said, the logbooks were a very promising research source for the group working on maternal health. So after providing a small sample of redacted pages, and you'll see on the screen here kind of what that looked like, the professor and I discussed research alternatives. And we decided that while their research time frame was about 10 years, they could still do good research with a sample of 1 year's worth of entries with all the PHI redacted. So we made scans and provided redacted digital copies of 1 year's worth of entries. So that was 1 full logbook. And we did this because we have a good relationship with the professor. We've worked with him before. It was a meaningful and important project on the history of health disparity in Durham. And we had 2 interns who were available to undertake the time-consuming scanning and redacting. So this is just one example of how you can grant access without IRB approval. The second collection I want to talk about is the Walter Kempner Papers and Records. Dr. Walter Kempner was a fascinating and, dare I say, controversial figure. He emigrated from Germany during World War II to join the Department of Medicine at Duke. And he was a creator of the rice diet. This diet is pretty much exactly what it sounds like. It's a very large collection with 450.6 linear feet in total. And there are 2 series of what we call yellow files, which are pictured here on the right. And we call them that just because they're yellow, but they are what you may have referred to as shadow charts. And there are 114 boxes or 171 linear feet of material. So here on this slide is an example of one of the files. This patient has been dead for more than 50 years, but most of them have not, and some are still alive. And as you can see here, in Kempner's just personal notations, he collected a lot of quantitative data, much more than normal. And so we were approached by a couple of retired physicians in 2019, some who had worked with Kempner previously, and they saw the potential in these records and were interested in creating a large data set out of these files. The team has since expanded to include several current Duke physicians and staff, which has been great. The proposed project involves getting all 60,000, we think, files scanned by a contracted company, the PHI redacted, the redacted file sent to a company for keying into REDCap, and then having a created usable data set that the Department of Medicine will maintain. So the project's still ongoing, currently stalled a little bit due to the pandemic, but it has been a very interesting and large and expensive project, one that I was initially very hesitant to get involved with, but so far it has been a really positive experience. And just some key takeaways are that these projects take a long amount of time. And so just like most reference teaching situations, taking time at the beginning to educate and clearly set expectations is so beneficial for the future. What was great for us was we were really transparent about what we would and wouldn't do, and we didn't make assumptions about what people knew. So for example, it was important to explain why we don't digitize everything, or why we don't want materials going through an automatic feeder. And we've really been able to successfully frame our conversations around me learning more about nephrology and the researchers learning more about cultural heritage materials. And also because this project is so large, it has required a lot of people and departments across the university to get involved, which has actually been a really positive outcome for us for marketing the archives and developing new partnerships.
Hi, this is Lucy again, and I'm going to speak now about how we used to process materials with HIPAA and how we process materials with HIPAA now. As a HIPAA-covered entity, we strive to provide access to collections without violating the law. Historically, we maintained a risk-averse mentality combined with more product, less process, or MPLP. This was done by indicating but not separating PHI from the rest of the collection materials. In the end, this process pushed researchers towards IRB approval, which is a very long and bureaucratic process. This image shows how we used to process materials with HIPAA by adding a red dot to the folder containing HIPAA. HIPAA and non-HIPAA documents within these folders are commingled. This method, using MPLP to process PHI and other HIPAA-related materials, created a burden on the reference archivist when these records were requested by patrons, because the reference archivist has to go through and identify the documents with HIPAA within each folder every time a request to see the materials is made. To create less of an access burden, we shifted the work to the front end, and now HIPAA is clearly identified during the arrangement and description of a collection. Depending on a few factors, like the size of the collection and time allotted to process, records with HIPAA are either put in a restricted series box or a restricted folder with a crosswalk back to the original location of the materials. Each collection, series, and subseries with HIPAA is identified on the finding aid, and a boilerplate restriction note is used. The image on this slide is from the Highland Hospital records, which is the collection we reprocessed to make more accessible by identifying and moving all PHI into restricted series. We selected the Highland Hospital records to reprocess because it's a high use and small collection. Highland Hospital was a premier residential and psychiatric hospital located in Asheville, North Carolina, owned and operated by Duke University from 1944 to 1980. The bulk of the collection contains records pertaining to the acquisition, administration, expansion of the hospital in the mid-20th century, and the sale of the facility in 1980. Records with HIPAA had never been identified beyond the folder level. After the collection was reprocessed, all records with HIPAA were moved into an unpublished restricted series, as seen in the image on the last slide. Collection and series level boilerplate access restriction notes were added, as well as an additional collection level note reading materials in box 3 are restricted and can only be accessed with the permission of the medical center archivist. The Department of Neurosurgery records was a new collection. The materials had been stored off-site for decades, and when they were recalled by the department, the records were pretty much just dumped into the office of one of the staff members. It was also her birthday the day we came to pack up the materials, and you can see the green balloon above Kaylee's head in the image on the right. She was very eager for us to get the stuff out of her office. While processing the Department of Neurosurgery records, we encountered a lot of PHI in both the patient records and the 16mm films. But their overall research value outweighs the fact that these materials contain PHI, as they document the work of the Department of Neurosurgery from the 1950s to the 1970s. Not taking the materials because of PHI would have meant their destruction, but if we took them and did not describe them on the finding aid, no researchers would know these records exist. In order to make these items discoverable and also ensure that no PHI was published, we carefully redacted all PHI from the finding aid, including not publishing any names from the patient index cards and redacting all PHI from the film titles. We also added collection and series level access restrictions notes to make it evident there is restricted material in the collection, as well as making it clear in which series the restricted materials are located. Here is an example of how we wrote the Department of Neurosurgery records, the finding aid, to make the contents discoverable, but also redact the PHI. The image on the left is from the audiovisual materials series, and you can see the patient's names are redacted. The image on the right shows how we labeled the film reels that are stored in our stacks. We created an internal-only spreadsheet with all the PHI listed so that information would not be lost. In conclusion, working for a covered entity has very real consequences when it comes to PHI and HIPAA, but this shouldn't stop archives from collecting archival materials that contain HIPAA with tangible research value. When a concerted effort is made by the processing archivist to identify and clearly restrict PHI at the time of accessioning and processing, it not only gives the archives more control over the collection, but it also makes the materials more readily accessible by lessening post-processing review of records. Keep in mind that processing records with PHI requires more effort on the front end and is not always ideal or doable based on staffing and resources. But if you're unable to spend the time identifying and segregating records with PHI, the end result is the non-HIPAA content is easily accessible, and the HIPAA content is made discoverable and available with proper IRB approval for future research.
Final conclusions for access. Because all collections are different and every research project is different, it is really important to have good reference interviews. When dealing with PHI, it is important to understand each researcher's time frame and research needs so you can direct them to the best path for access. It's also really important to understand what you can and cannot do and why, and then be able to clearly articulate those things. It is hard to tell people no, but it's always better we can tell them why you're telling them no. It just makes for a much more productive conversation. And making decisions involving PHI alone can be stressful, so it's really important to find people at your institution to support you. We are fortunate to have bosses and supervisors who really support our decisions, and we have also tried to make connections with legal and research partners across Duke who can advise us. So finally, we'd recommend doing your due diligence. I send lots of emails with lots of questions to people who are way above my pay grade, and then document everything well, because people don't always remember what they told you, and then relax knowing that you did what you could, and if you documented it and did your due diligence, then the people at your institution hopefully will support you. And so here are just some resources of the collections at our archives and some HIPAA resources. And then here's our contact information. We would love to talk to you more about HIPAA and processing and all of that.
Lucy and Rebecca, thank you so much. Very appreciated. Our next speaker is St. Louis at the Bernard Becker Medical Library.
Good afternoon, everyone. I hope everyone's doing as well as we all can under these extremely interesting circumstances. So basically, in the special collections world, the question of how we can get students to engage and interact with the primary sources we hold has been basically a really kind of hot topic for a very, very long time. So this is basically going to be a look at what we've been doing at the Becker Medical Library, and so hopefully it can be useful for you or give you some things to think about if you're kind of looking at ways that you might be able to get more student interaction with your collections. So a few things just about the Becker's situation. So we are very much kind of the odd man out within the Washington University library system. We are the only one of the libraries that is not really under the main library system. So all of our holdings are cataloged on a separate ILS. You have to be on the medical library webpage specifically in order to search our holdings. Also, we are physically distant from the main campus. It's a couple miles between us, and it can take a lot of time to go back and forth. We also still do have our own special collections division within the medical library. So those hold the archives of the medical school, which go back to the 19th century with our two predecessor organizations. And then we also have our rare book collection of about 17,000 volumes that date from the 15th to the 20th century. And so those are also all within the medical library on our ILS in our separate location. So that's kind of what we are working with. So when it comes to instruction on the medical campus, one program that we've had a lot of success with is these things called the first year selectives. And that's basically just the term that WashU uses for an elective course. And so we have done those in collaboration with the Center for History of Medicine, which is an independent entity within the medical library, headed by a member of the medical faculty. And one of their primary programs has been teaching these selectives. So there are 3 of them offered each year, and each one of them lasts for 6 weeks, and all of them focus on some aspect of medical history. So the most common ones have been things like the history of anatomy, the history of epidemics, which has, of course, turned out to be extremely relevant, and then also the connection between war and medicine. And so the format for these was pretty standard. The students would begin by having a discussion with the faculty leader about the readings for that week, and then they would come up into the rare book room where we'd have a display of rare books and archives that basically relate back to whatever the topic was for that week. So you can see an example of one of those in the slide there. That was for the week on classical medicine. So it would basically be a chance for students to learn about a topic, and then they would be able to come in and basically see, here's the historical basis of this topic. So there is a catch with these, and that is that we are very much at the mercy of what the medical curriculum office wants to do in regards to teaching medicine to medical students. So somewhat ironically, just a few months ago, we got the news that the selectives are no longer going to be offered because the university wants more of a focus on clinical medicine. And the medical student schedules are just very, very, very planned out. Every hour is accounted for. I'm sure that's pretty similar at a lot of your institutions. So unfortunately, we're no longer going to be able to offer selectives in this format at this time, although we are always optimistic for the future. But just because you can't necessarily have a classroom setting doesn't mean that you can't teach medical students the history of medicine. So one thing that we do every year is we have our annual anatomical display, which actually originally started for the medical students. Now it's open to the public, but definitely the most people who come are these medical students because it coincides with the end of their first session within their first semester working within the anatomical lab. So what we do is we take a selection of our atlases that date from the Renaissance all the way up to the 20th century. It's usually maybe about 25 to 30 books all laid out in chronological order. And so then the students basically have a chance to come and explore the history of their profession. So over the years, we've added kind of more ways to give them more information. We've started doing sort of self-guided tours where we give a number to each book and then make handouts so that even if there are a lot of people in the room at one time and the staff can't necessarily talk to all of them, there's still information for them to have and to look at. And so students have really responded well to this. They love coming and having the chance to see these books in person and up close. And so kind of along those lines, this past year, we also started to do monthly open houses that are on different topics. So we were originally going to do graduation for this month and do historical photographs of medical school graduations. We've had to shift gears slightly, basically based on which objects we can post digitally through our social media feeds. But when we can do them in person, things like graduation, things like medical advertising, things like botanical texts, sort of any different topics on the history of medicine that the students can come up and look at if they're interested in it. So it's kind of like, it's a way of still giving them instruction in a less formal setting, but it gives them the chance to come on their own time when they're not being mandated by their curriculum. You need to be doing this at such and such a time. So we also do some instruction with the undergraduates as well, the ones who are located on the main campus. And so the classes that come and visit us are usually in the areas of art history, gender and sexuality studies, history of scientific developments, and also philosophy. And so these usually follow a fairly standard show and tell model. One thing that a lot of special collections librarians are interested in is sort of finding ways to move away from show and tell and kind of make these sessions a little more interactive and a little more student driven. This can be tricky sometimes, especially if, like the Becker, you're physically distant from the main campus and it's difficult to get students to even come to you in the first place, or else they're very much on a time on a time limit because it takes time to get to the medical campus, it takes time to get back. They only have a set amount of time. So for us, doing kind of these week-long projects where they can pick one book and kind of explore it throughout the semester, we haven't had much success with that. But there are still some things that you can do. One professor actually has assigned each student a book to research prior to the class. And so then when they come in, I'm sort of an accessory to the presentation, but it's really the students who are the ones presenting on the books, and they're the ones who finally get to sort of meet their artifact. Another thing that we've tried is giving out handouts to the students so that when they come in, they can kind of have a way to engage with the books. So we've kept this pretty simple, like even just things like if you read a paragraph of text from the 16th century, what strikes you about the language, or what strikes you about the illustrations? How are they different from medical illustration today? So you can find fairly simple ways that can still get the students interacting with the text more so than just you telling them about the items. Another thing that we do is sometimes we have taken some of our books over to the main campus to show in their special collections classroom over there. Really the most important thing for institutions like ours where the medical library is separate is that relationship building is really, really, really important. If there are professors you know who have used your collections and are interested in the subject material, that's definitely a relationship that you'll want to cultivate. Also, I have an open line of communication with my counterpart on the main campus, and having that is really important as well. One thing that sometimes seems to be the case if you're in one of these special libraries is that sometimes you really do have to take the initiative and make sure that the people on the main campus know that you're there. Since sometimes it can be a little bit like out of sight, out of mind. So you really have to make sure that if you get a good channel of communication with certain professors or with other librarians, that you don't let those relationships go cold. Because that way, if they know, hey, we're doing a class on something like Frankenstein, the history of Frankenstein, do you have things in your library that can be relevant to that? You'll be on their mind, and then they'll be sort of willing to work with you to bring their students in and sort of make use of your resources. So thank you.
Thank you so much, Elizabeth. Now we have plenty of time for questions. And Rachel, I saw that quite a few things came through over the course of the talk. So I don't know if you have a handle on that, but I can help if you need.
Yeah. Why don't we go up to the first one just to try to make sure everything is grabbed. And I think the first one was from Paulina for Lucy and Rebecca. She asks, are you planning to create, Lucy and Rebecca, if you're still around, are you planning to create just one redacted data set, or will you have another unredacted data set that can be accessed after receiving an IRB approval?
Yeah, so my understanding, because I am not the head of this project, is that as of right now, the archives will maintain the unredacted digital scans, and those can be accessed after receiving IRB approval. But in terms of what is going to be keyed into REDCap, that will all be redacted and will not have the PHI, because really I think the researchers and clinicians at Duke are really interested in looking at the data set as a whole. And they're really particularly interested in the quantitative work that they can do with it.
Okay, we have another one for you, Lucy and Rebecca, from Jessica Sedgwick. Is the approach of physically separating records with PHI now the default processing approach, or is it something you apply to just high use or anticipated high use records?
Well, pre-pandemic,
it was applied more liberally to collections that we thought would get high use, or that we thought had particularly valuable information. Post-pandemic, the future of having interns at our archives is up in the air about when we will get them back again. Both of our interns are graduating, and they help with a lot of the processing. And anyone who's done archival processing knows that it's quite time consuming, especially if you're working in a covered entity and you have to be very careful about PHI. So I would anticipate that due to lack of resources, we might go back to a more just maybe separating very quickly at the folder level and more accessions level processing. In a perfect world, if we were able to have 2 interns as well as myself processing and working on these collections, then it would be more, we use it more liberally than I think what's going to be coming in the next few months.
Okay, let's see. We had some messages, questions for Chris, right? Chris Ryland, you're still here, from Shelley. Could you share what year the student was, the intern, and what their background was?
Yeah, sorry. So yeah, she was graduating. She's a graduating senior and a history major, and she was interested in maybe a career in cultural heritage. Yeah, so she's yeah, so she's a graduating senior.
And another one for you, Chris. Shannon Adele is asking, who did the photography and the website layout?
Oh, so the photography was done by a member of our communications team for the main library, and the WordPress site is done by our library technology group. So they made a WordPress template that we use for all of our online exhibits.
Okay, my chat has just gone haywire. I think there was a question for Elizabeth. Let's see.
Yeah, Rachel, there is one. It says, for Elizabeth, is there a virtual open house of anatomy books? Would you be willing to share your self-guided handouts?
So we haven't done a virtual open house as of yet, but I'm sure that that is definitely going to be under discussion now, since probably we're going to be back at work, and then there will still be limits on how many people can gather in one place for who knows how long. So that I would definitely be expecting us to be exploring that possibility for this year. And yeah, I would be happy to share the handout with anyone who would like them.
This is Meredith. It looks like there was a question from Phoebe for the Duke group. Phoebe, if you want to get on the mic and ask your question.
Okay, so I've unmuted. So I had 2 separate questions. One was, were there any considerations for North Carolina state laws regarding medical records or PHI? If that, I'm not familiar with what North Carolina laws are, whether they have longer or restrictions or not. I know in Maryland we have longer restrictions for medical records than what HIPAA allows for PHI. And my second question was, with the, I've struggled as well in terms of processing collections over the years, with it, because the rules have changed from 2003 to the 2013 change. With this, how much you keep the PHI within the folders, intermixed and, flagged and notes on folders versus segregating it into their own separate folders and boxes. And that may depend on how much you're going to be, how actively you're going to be servicing that collection. You just screen it for this one researcher who, and you're probably not going to have another researcher in 10 years. We're just going to be an actively used collection where it makes sense to just keep that PHI in a separate segregated folder. And so we've kind of done a case-to-case basis with collections at Johns Hopkins. And so I was wondering if you were intending to move the documents that you've segregated into these separate, boxes and folders back into the rest of the collection, in a sense, kind of, reprocessing the segregated stuff once it's no longer protected by HIPAA. Of course, that may vary based on the dates of materials that you're segregating based on those dates.
Phoebe, this is Lucy. I heard most of the second part. Your audio was kind of going in and out a little bit. But for the North Carolina laws, no, they don't affect the national laws in a way that we have to be careful, like Maryland, I think. And then for the second part, most of the items, if they're restricted because there's an available death date, then perhaps that's something we could look at in the future. But by and large, most of the information that we do have restricted is because there's no death date available with those records. So there's probably no way, unless someone went and did some research about each individual, to add them back into the rest of the collection. Did I answer the second part of your question, Phoebe?
Yeah, I would offer a little bit of advice on that part. I developed a kind of a workflow in terms of at what date you can assume somebody's been dead long enough. This is something that I presented at SAA a few years ago, and it's available on the SAA website. So it's something that I can share. But we do, it's really labor-intensive process to be processing, collections and screening for PHI, and that's something that we're going to struggle with as well. When are we going to be able to have students come back? Because the students are the bulk of who's doing that screening work. Sometimes you do know the death dates, and that part varies. So that's where you kind of look at age of the individual when the PHI occurred. Were you talking about children in the 1940s where they could easily be still alive, or are you talking about a patient class that were in their 70s in 1940s, in which case they were probably dead by 50 years ago in 1970.
Yeah, Phoebe, I think a lot of it, like what you were saying, goes back to risk management and managing risk in terms of, like, if you have information from someone who died or who was born in like 1850, what's the possibility of that person being dead for longer than 50 years? Probably pretty high. Duke is the hospital is fairly new, so so a lot of the patients and a lot of the records we have, it's harder to categorize quite like that, as the School of Medicine started in the late 30s.
It looks like Megan Keller-Young had about 2 questions. Megan, are you there? You want to ask them?
Yeah, sorry.
Oh, that's okay, no problem.
I had to plug in. My question was, firstly, if you get any researchers who aren't affiliated with Duke who want to see the documents with PHI and what your procedures are with that, and if the standards that you use to deal with the PHI, is that in the department policy or collection manual?
Yeah, so this is Rebecca. Actually, since I've been at Duke, I haven't gotten any requests for non-university researchers. I mean, I have gotten requests for things that's related to their own records, and that's like a whole different thing. But for non-university researchers, I have been in consultation with the director of the IRB, and they had me go ahead and create like an open protocol that I with the IRB, where I'm listed as the principal investigator, And they said that, and so the idea is that non-university researchers could come under my open protocol, where I'm the PI. So that is the process that the IRB and I have talked about, but I haven't actually had to do that.
Yeah, I'm kind of in the same boat with the researchers. Is your standards in a department policy or collection manual?
No, I don't actually think that standard is. Yeah, I don't think that's right now anymore. But that would probably be a good thing for me right now.
We have a this is Lucy. We have a processing manual that just talks about how to deal with PHI. It's internal and something that we wrote ourselves and the interns use for processing.
Great, thank you.
It looks like Charlotte Lellman also had something for Rebecca and Lucy. For separated records with PHI, how do you deal with unrestricting, especially if records in a file could have different dates for opening?
Well, this is Lucy. We haven't technically unrestricted any. This has been within the past year or so, and nothing has hit up on that 50-year death date. So we haven't unrestricted anything other than reprocessing the Highland Hospital papers, which had all the PHI intermingled with all the rest of the records. And as far as I know, the death dates are written on the restricted folders when they're available, and it's something that I think that I would need to review each collection to manage that, and that's something that's also very heavy on resources. And so unfortunately, for a smaller collection or a more high use collection, it would most likely get more attention than a larger collection that perhaps isn't as used. Highland Hospital is used a lot. It's the hospital that Zelda Fitzgerald, she was in, and there was a fire and she died, and we don't have any information about her in it, but a lot of people want to see the collection because of that.
Two things. One is Russell Johnson's just saying that the HIPAA page was last updated on her website in 2014, so plenty of room for additions. But the last question it looks like I'm seeing is from Shannon Odell. For the Duke team again, can you vet the formula regarding release date for patient data with the university's general counsel?
So that is the university's general counsel actually looked at, well, first off, Duke is very risk averse. And Rebecca, please chime in if you'd like to. So the Highland Hospital papers, I went against what the general counsel wanted us to do. They looked at the whole collection and they said that the entire collection should just be restricted. Because it was so small, I could look through it, and to me, it seemed like it would be a good thing to go through and make it more accessible. Rebecca was getting requests for it a lot, and she was having to go through folders herself as a request came in and looking for PHI within the folders that had a red dot on them. So I'm sure if we were to discuss something with general counsel, they would tell us, no, don't make it public.
Okay, thank you. I think we have time for one final question. Are there any other questions from our audience? Okay, going once, going twice. Rachel, did you want to add anything or wrap up?
I just wanted to thank everyone who presented today. This was incredible from this very start to the very end. I'm just super impressed by everyone who's presented today. You guys are super amazing. It's been really, really fun. It's been really great to not be thinking about a pandemic and hearing about what everyone is working on and doing. So thank you to all our presenters. I'm really glad we'll be able to do it again tomorrow. Tomorrow we'll start at 1 o'clock Eastern time, 1 p.m. We'll wrap up by 2:30, 2:45 tomorrow. And Melissa, will you be sending out a new Zoom link and password, or will we be using the same one?
You know what, go ahead everybody and use the same one. I don't think there's any limitation. I could be horribly wrong, but as far as I know, it's open. Nothing's going to stop it. So I will email everyone via the listserv and just confirm that you should just use the one that you've used today, and we will hopefully we'll see everybody come tomorrow for the second session. Keep in mind, if you're trying to attend the AAHM sessions that are going on at the same time, there's one that's opposite us. They will be recording those panels, so please join us tomorrow for round 2.
Thanks again, everyone. Everyone
Okay.
was really great. Thank you.
Thank you, everybody. Glad to hear or see some of you, and we'll talk to you tomorrow. Bye, guys.
Bye-bye.